we are. So let's go here. Everybody, while I'm working on my slides, it's an honor to be here with all of you. I have always enjoyed education. For those of you that know me or have heard me speak before, you know that I can always entertain and educate. So what I'm hoping today is that we get through the content in time for questions, but I realize that we might not. So I appreciate Maureen and June pushing me any questions via email, and I'm happy to get back to you. Maureen, my share isn't working. Do I need to be the host, please?
No, you should be able to share. It's open. Do you want me to pull them up?
Yeah, it is not pulling on my end, and that's why I'm wondering.
It's okay. Let's do this.
Let's see. Hold on. We're good, everybody.
There you go.
How about this? You know what? There are way too many buttons on this machine. All right. Well, again, I am so happy to be here with the Case Management Society of New England for this fall virtual conference. We're going to dive right into spirituality in healthcare. Certainly, I'd love to hit every high point in this content. So this is just a taste, everyone. I'm going to feed you enough to get you as fired up as I am about how a spirituality assessment, asking key questions can help us with our care transitions, our discharge planning, or even in what certainly our grandmothers told us was a hard conversation. I don't know about you, but my grandmother was pretty clear that you didn't talk about religion, sex, and politics in polite company.
Elaine,
Here, yes, ma'am.
could you go to slideshow from the beginning?
Yep, I did that. Is it not working?
No, it did not.
All right, let's try this again, everyone. Thanks for the patience from the beginning. Maureen, how about that?
Nope. Did you share again?
All right, let's go back again, everyone. Yeah, let's get that out of there. And down. Does everybody have the handout, Maureen?
It was available for them to download, yes.
Okay, great. So folks, I've been known to talk while we're working on the tech. Go ahead and look at the objectives this morning.
Okay.
And look at what we're going to be taking a look at. We are going to be looking at the, excuse me, how spirituality is part of our inclusive healthcare. And then we're going to be looking at items related to mortality and suffering. Maureen, are people able to see the slides now on share?
So if you click on schedule back up later.
Let's just get out of the slideshow. And
do you see that bar that says schedule back up later? The yellow bar, back up this.
I do not see a yellow bar. Oh, right here, yellow bar. Yes, ma'am.
Now hit slideshow in the bar.
Yep. From the beginning. How about now, everybody?
I think it's, no, hit slideshow one more time.
Okay. And now?
No, but that's okay. Why don't we just go? It just has a sidebar with your all your slides in it, but let's just go because the main ones are there.
Okay. Again, everyone, thanks for being patient. Again, I hope everybody downloaded the handout because your information is there as well. So I don't want to burn time on tech trouble, so I know everybody can read those objectives. So let's talk about spirituality. You know, that means different things to different people. I hope everyone realizes that. And so to offer a foundation, we need to look at some key data and also look at some organizational directives and accreditation. Also, I'd like you to consider what are the spiritual influences that impact an individual's healthcare decisions, their daily life, and their care choices. I think certainly, even though we don't think automatically about spirituality, we're usually thinking about all those biopsychosocial things, or as our previous speaker pointed out, a lot of other complex areas that may overshadow a spirituality assessment that could really have influence on our individual's decisions. So we do want to be sensitive to people's faith traditions, spirituality, and religious beliefs. You also need to acknowledge your own religion, faith, and spirituality in order to have an effective conversation. And of course, we want to advocate for those with differences. The National Cancer Institute in 2022 took a look at what patients wanted their healthcare team to talk about in regards to their spiritual needs. And there you have the overwhelming request that greater than 3/4 of those patients wanted their team to incorporate their spiritual needs. So how do we do that? Where's the assessment? What questions can you ask? I'm going to get to that, everyone, in a little bit. In another study, a pilot study with African American men experiencing prostate cancer, reported that most of them discussed spirituality and faith with their healthcare team. They felt that it was an essential part of their care. And I have a third piece of research for you. And this one, I think, really speaks to our need to address spirituality. Patients and clinicians were asked to rank 7 factors that influence or were important when making care decisions. So there were 7 elements that they were asked to rank, 1 through 7. So 1 was most important and 7 was least important. Here are the results that are fascinating regarding spirituality. So for the clinicians, faith in God or spirituality concerns was number 7. It was at the bottom. For the patients, faith in God or spirituality concerns was number 2. So what does that tell us, everyone? See the gap or the disconnect? Absolutely. So clearly, our patients, families, caregivers, clients, because I know we interchange patients, clients, and individuals. You'll hear me switch out this morning. This is a key element in person-centered care or holistic care. And it's not just an end-of-life issue. And how many times have any of us working with an individual and their family and caregivers only heard a conversation about spirituality when it's an end-of-life issue, when someone's enrolling in hospice? I'd like us to consider a spirituality conversation way before any end of life concerns. So I've given you some good data to look at as far as reasons to assess spirituality. But why else do we need to take a look at this? Well, we have organizational directives and professional imperatives that also say, take a look at spirituality. So let's start with the Joint Commission. I think everybody recognizes the Joint. What's interesting with the Joint Commission is certainly they say facilities are accountable for maintaining patient rights, that there needs to be accommodation for preferences and values, but the Joint does not have a prescriptive requirement to assess spirituality. So how would you meet that? If it is important to your individual family caregiver, how would you take a look? How would you assess that? Now, if we were in person or I wasn't mindful of our time, I'd throw this question out to all of you and say, what questions would you ask? But I'm going to go ahead and give you some of those answers. The Joint Commission does offer some sample questions. Some of these are, who or what helps get you through illness or injury? A second one, who or what provides you with strength or hope? Or another one, how does your faith help you cope with illness? The next statement I'd like to look at is from the American Nurses Association. And the ANA has always been clear that nurses support respectful, humane, and dignified care, respect for human dignity and the uniqueness of the individual, with the following considerations that you see there. So when the code for the American Nurses Association is talking about optimal nursing care, they're looking at enabling the person to live with as much physical, emotional, social, and religious or spiritual well-being as possible. And it should reflect the person's own values. Our social work colleagues in their code of ethics also talk about the dignity and the worth of the person. Again, social workers look at promoting self-determination, enhancing client capacity, and addressing their needs. When we look at the rest of the code of ethics with the NASW, please note they do specifically mention religion here, which I was very happy to see. Let's look at our case manager professional organization. I know everybody out there has read the standards of practice, updated in 2022 with the guiding principles. Just in case you have that in your reading stack, I'm going to hit some high points for you. So when we think about spirituality with the guiding principles for the CMSA, you'll find these on pages 14 and 15 in the standards of practice. The CMSA says we are client-centric. We offer comprehensive, holistic, and compassionate approaches to care delivery. And of course, we practice cultural competence, linguistic sensitivity across the diverse populations that all of us certainly have offered case manager services. The guiding principles talk about facilitation and connection with community support and resources. And then this one is my favorite when I am offering a continuing education or a seminar. Professional knowledge and practice excellence are part of what you need to pursue as a case manager. And certainly, Practice excellence is why all of us are together today. And I want to offer a little sidebar. Kudos to all of you taking a Saturday morning to participate in this fall conference and continue your lifelong learning. How about for everyone who is a certified case manager as a CCM? What does the CCM Code of Conduct and Ethics have to share with us? Again, inherent dignity of all the clients. The case management body of knowledge, the CMBOK, certainly addresses cultural identity. Honoring that respects other choices, decisions, and behaviors as long as they are lawful and not proposing a risk. So the self-determination and the autonomy, that principle of autonomy, is really essential in so many areas of our case management practice. But when you consider it for a discussion about spirituality, it truly is all about that person's values, beliefs, and practices, and how their cultural and spiritual influence impacts their healthcare choices, their access, their choice of providers, so many elements. And again, I could probably do several hours on this topic, but today, again, just a taste. I'm hoping to get you excited about asking and inquiring and including a spiritual assessment for your patients, families, and caregivers. So we've taken a look at the why we should explore spirituality with our population. Let's move on to some definitions and some other information that can help us formulate an assessment. So again, religion, sex, and politics, hard conversations, topics that our grandmothers said we shouldn't talk about, but here we are today talking about one of them. It is, again, so essential for person-centered or holistic care, and certainly emotional wellness. And we'll touch a little more on that a bit later. But consider, everybody, how comfortable are you with these discussions? Well, before you think about having the discussion or conducting an assessment, we need to look at some definitions: religion, faith, and spirituality. And I offer you these definitions in context for this conversation, this presentation that we're sharing this morning. Certainly, any of you could probably expound on some of these definitions, but we have to start somewhere. So this is what we're going to use. So there's your definition of religion. It is an institutionalized system of attitudes, beliefs, and practices. It also can include sacraments and ceremonies, traditional observances, holy days. For faith, please consider that it's trusting in something you can't see, hear, or feel, so you can't prove it. It's an unshakable belief without proof. And then spirituality. The definition that I'm sharing here is a combination of a couple of the references that are at the end of my session that I'd encourage you to take a look at. But again, for the purposes of our conversation this morning, spirituality is a belief in something beyond yourself. It's a connection to others in the world, or certainly it can be defined as that which gives meaning, purpose, or hope in life. I want to stop for a moment and give you my first takeaway message. So if you get nothing else out of this morning, here's my first takeaway for you. Please consider that a person can be spiritual and not religious. So I'll just repeat that quickly. People can be spiritual and not religious. Well, let's take a little deeper of a dive into religion, faith, and spirituality. What you have here on this slide is generally considered the world's 8 great religions. And again, religions include clerical hierarchies, prescriptive practices, sacred language, rituals, feast days, and holy days. I would like to remind everyone that religious organizations and those faith leaders have been involved in healthcare for millennia. So healthcare and religion, faith and spirituality have been tied for a very long time. I'd also like to share with you some numbers related to the world's 8 great religions that you see there. For the whole world, 31% are Christian, 23% are Islam, 15% are Hindu, 7% are Buddhists, and less than 1% practice Judaism. Here in the United States, 70% are Christian, 2% practice Judaism, 1% Islam, and 23% are unaffiliated. So when that poll was done, almost 1 out of 4 Americans said, I have no religious affiliation. So I come back to that first takeaway message, everyone. People can be spiritual, but not religious. 23% here in America are unaffiliated. Moving on to faith. Some of you may have heard this presentation before in the last couple of years, and I continually come back to this content by Mr. Teller because this means so much to me personally that I want to share it with everyone. This is a very worn yellow piece of paper in a plastic sleeve that hangs on my wall right above my computer monitor where I spend a lot of time at work. I bet you do too. And I don't usually read my slides, but I would like to read this to you. This is a definition of faith. When you come to the end of all the light you know, and it's time to step into the darkness of the unknown, faith is knowing that one of 2 things shall happen. Either you'll be given something solid to stand on, or you will be taught to fly. This is so meaningful for me in terms of faith because this was given to me when I was going through a really difficult time with some illness, both physical illness and social mental health illness. And a fellow case manager gave this to me. And I have kept it all these years. Faith is knowing that one of 2 things shall happen. Either you'll have something solid to stand on, or you'll be taught to fly. How about spirituality, everybody? The purpose of life is a life of purpose. Again, your spiritual practices may not be linked to religious practices. So an individual who says, I'm not religious. I don't have a religious home. I'm not a practicing fill in the blank with whatever religion, but I do have strong spiritual practices or strong spirituality. So that certainly could be whoever or whatever gives them ultimate meaning and purpose to their life, how they connect to others and the world as a whole. So certainly I will come back to that message. So here's your second takeaway, that integrating spirituality or an assessment into a care plan or into the healthcare delivery for a person assists them to reach their best health. Next, I'd like to share with you some other spiritual concepts, spiritual distress and moral injury. I recognize that both of these could be their own content and their own session. So again, this is an overview for you because many folks who have strong religious beliefs, faith, or spirituality could certainly experience either one of these issues. So let's look at spiritual distress. This can start with a big question. Why is this happening to me? Their distress comes because there's a conflict or a dilemma between what they're experiencing in their life and their beliefs. Some of the causes that you see here, but that big question in spiritual distress is, why me? Another question that could come up is, why has God abandoned me? If there is a God or monotheistic belief there, why has God abandoned me? And we can see spiritual distress exhibited through some of these symptoms that you see here, particularly hopelessness. Why have I been abandoned? People experiencing spiritual distress may ask, what's the meaning or the purpose to this suffering? And we're going to talk about suffering here in a little while. So that's an overview on spiritual distress. Let's just take a look at moral injury, because morals and religion, faith, and spirituality are certainly intertwined. So the first point I'd like to make is actually the last bullet on the content. Moral injury is not burnout. Moral injury is a deep emotional wound as a result of seeing, feeling, experiencing, witnessing human suffering or cruelty. It is both a cognitive and a feeling or emotional response because what you've experienced violates your own ethical code. So you feel threatened to your core values. There's certainly psychological damage from continuous exposure, and you see some of the symptoms here. My example to share with you for moral injury is the experience from the pandemic. For any of us that cared for individuals living through or succumbing to COVID-19, there were certainly healthcare providers with moral injury. There was an experience and a threat to their core values, caring for so many of these patients who would not survive their disease trajectory. You know, you think about all that news coverage, or maybe your own personal experiences with the facility you worked in, or patients and families that you cared for. So there was certainly an ethical problem. And what was that? What was the dilemma? Well, we wanted to do good, beneficence. We wanted individuals with COVID to have their own decision making and their own self-determination. So that's the principle of autonomy. We also wanted to avoid harm, non-maleficence. But how challenging and how difficult was that for any of us during the pandemic and caring for so many people? Caregivers, particularly in the ICU, when I think of some of my colleagues and experiences there, felt this strong professional obligation to care for these people, for these patients. Their families were not around. Communication was happening by phone. So kids could say goodbye to mom and dad. So adult children could say goodbye to parents and grandparents. I'm sure we all recognize the heartbreak there, right? And so our fellow professionals really struggled and truly saw they had an ethically correct obligation, but they couldn't carry it out, whether that was the disease process, system barriers, internal or external constraints. It just wasn't there. So they experienced a moral injury. Now, some of you may say, well, Elaine, they all had post-traumatic stress disorder or PTSD. Now, commonly, many of us call it PTS without the disorder word at the end. And certainly in my work with the military, this is part of my daily practice, is working with individuals living with PTS. And that is a moral injury. And it is very challenging, as certainly we all recognize, because the prolonged exposure to events that involve suffering or cruelty, whether that's war or whether it was taking care of COVID patients in the ICU, certainly leads to this psychological damage. Right. Well, I've given you some foundations. Let's move and talk about spiritual well-being. Certainly, this is something that we all would embrace and agree this is a good place to be, well balanced in our spiritual practices, and whether that's religion or faith. But what does it look like? You know, I'd like to be as calm as this individual, I hope, is experiencing, looking at this sunrise or sunset. It's a little hard to see. The pink sky could be either. But what does this look like? So with one of the references I offered you, they've enumerated, here's what spiritual well-being looks like. It's connection to that higher power. It's emotional resilience and a sense of belonging. It also improves our mental, physical, and emotional health. And toward the end of our session this morning, I'm going to share with you some information on the impact of spirituality and outcomes, because we're case managers, we're all about outcomes, right? So think about spiritual well-being as a state of contentment, balance, and harmony from meaningful connections with one's inner self, your values, and your beliefs. So again, I think this is the third time I've said it, everybody, but you can be spiritual without being religious. And that leads into why in the abstract for this content, I mention that spirituality is more than checking the box on that intake for religious preferences. That doesn't quite cut it in terms of a deeper discussion. So, what enhances spiritual well-being? How do we get there as case managers? What can we do to assist our patients, families, and caregivers to move toward spiritual well-being or maintain it? So, and again, if we were in person, I would throw this out to the audience, but I'm just going to mention 4 items here. And then certainly in the Q&A or the chat, if June and Maureen will help out toward the end, we can take a look at this. So think about what practices would enhance spirituality or your spiritual well-being. Prayer, meditation, journaling. For me, there's a reason why there's paper and a pencil next to my bed at night. It reminds me that I want to write down my 3 gratitudes for the day. And I have to tell you, everybody, some of those gratitudes aren't necessarily, deep and profound. Some of them are, I got to have lunch today. My dog was so happy to see me. And then some of them are a little deeper. But journaling can be very helpful. And finally, reading and reflection. And I think it's reading anything. It does not have to be from a spiritual faith religious leader. You could be reading something nonfiction and find it meaningful for yourself. So think about, do you do any of these well-being practices right now? And if you do, I hope they're working well for you. But also, I would ask, what ones might you suggest to an individual or their family and caregivers? Because case managers, we're pretty innovative people. We are problem solvers. And looking at this spiritual aspect of an individual related to their healthcare delivery might mean that, we ask about how they practice their spirituality. And that could include prayer, meditation, some of the items that I've already mentioned this morning. Well, now I'd like to talk about one of my other passions, social determinants or social drivers. And the purpose of this slide is to sell all of you on the idea that spirituality is a social determinant or a social driver. Now, remember back at the beginning of this conversation, I mentioned that healthcare and faith leaders and religious organizations have been involved and intertwined for millennia. Well, fast forward to our current life and times, and why is spirituality a social determinant or a social driver? And you'll hear driver and determinant used interchangeably. I'm learning to call them social drivers more and more, mainly from my social work colleagues who reminded me that a determinant sounds like it's defined in an endpoint, but a driver keeps going. And I thought, yes, that's why they're social drivers. So many faith communities stepped up during the pandemic. Maybe you all have known some or were involved yourselves. They were really public health leaders. There was vaccines available at faith communities, information, education. and certainly personal protective equipment. That's PPE. I'm sure a definition that everyone here recognizes. In addition, and I was surprised about this, I admit that I recently discovered the White House Office of Faith-Based and Neighborhood Partnerships. It's been going on for over 2 decades. This office looks at access, coverage and reimbursement, mental health, increasing vaccine rates. And that's not only COVID vaccines, everybody, that's every vaccine. So like big flu vaccine partnerships and suicide prevention. And I can certainly say I've seen this in action. And as I thought back, I'm like, yeah, I wonder if funding for all those thousands of flu shots I gave when I was with the Visiting Nurse Association in Richmond, Virginia for 5 years, had some funding from this White House office. Because folks, I can tell you, I gave a lot of flu shots at faith-based locations, church parking lots, after services or mass. It was wonderful that all these partners reached out to the VNA to bring flu vaccines right to their congregations, parishes, and communities. One of the latest things going on, which I have great hope for as far as a Medicaid waiver, is Medicaid Section 1115. For the purposes of this discussion, everybody, I didn't give you a deep dive into that Medicaid waiver, but I promise you, you can search it and learn more. What this Medicaid waiver is asking, and California's been successful, is to allow partnerships with faith communities so that the faith community can assist with any number of the social drivers. Is that food? Is that transportation? Is that education? You know, does the faith community have daycare, preschool, a school for kindergarten through 8th grade, or even right on through high school, so that those receiving Medi-Cal in California under this Medicaid waiver would be able to have access to these services. Now, personally, I think this sounds fabulous, because any of us that have worked with people receiving Medicaid benefits, and we all recognize those are different state to state, understand that there can be struggles in any number of areas, whether it's getting the meds, having transportation to the doctor's office, having enough food to get through the month. And that's another one of my CEs, but we're going to concentrate on spirituality today. Or, you know, finding adequate education for their kiddos. So I'm going to keep my eye on this, because I'm hoping that this waiver is considered more and more by each one of our states and territories, because there's some good work being done here. So when you look at spirituality as a social driver, keep in mind that it is intertwined with health and health policies. And so policies and practices. And whenever I say policies or I hear it, I always think, yeah, legislation. So that's our local, state, and federal government, you know, coming together and recognizing that what would our health system look like if we really engaged with spirituality as a social driver. If you are more interested in this context of spirituality as a social driver, I'd refer you to the reference on my list from Long and her colleagues entitled Spirituality as a Determinant of Health, Emerging Policies, Practices, and Systems. So take a look at that, everybody, if you'd like more info. All right, a little bit of a breather here before we take another dive into some content. For those of you in Texas, I know there's one person on here from Texas. These are Texas wildflowers, bluebonnets, Indian paintbrush. This is the time of year I miss Texas, not August, wildflower season. So as we take this little break here in the content, I want you to consider that I'm not asking you to be a spiritual expert. I'm not a spiritual expert myself. I'm just very engaged and interested in exploring and assisting people to have their best health outcomes, to be their best selves. And if spirituality is part of that, then as a case manager, it needs to be an element of what I include in their care plan, in a daily interaction. So I'm not an expert in every faith tradition or religion. I mean, neither are you, right? But we do want to be informed on those beliefs and how they impact our care choices and influence healthcare decisions, and recognize that for some individuals, their religion, faith, and spirituality is core to how they cope with their health challenges. Because we care more for more than the disease or injury, right? We don't call people the gallbladder in room 214, or that crazy no good rat son that visits his mom. We try not to label people, of course, and we do look beyond the disease or injury that people are living with or experiencing. So as we move forward in our session right now, I'd like you to think about, what experiences have you had as a case manager where an individual's spirituality influenced their healthcare decisions? What have you run up against, been challenged by, or discovered as you worked with somebody whose spirituality, religious beliefs, or faith were integral to how they approached whatever illness or injury they were experiencing? So tuck that away and think about it. Certainly, I want to point out that there are decisions and choices that are influenced, and some of these you may be familiar with or not. I think we're all familiar with blood transfusion beliefs with Jehovah's Witnesses. For Muslim women, they will only see female providers. In Judaism, no embalming or creation. And certainly in Buddhism, Buddhists have a strong influence on their spiritual practices. I will mention that for Islam and the prayer 5 times a day, I have a quick story to share. I was case manager in a cardiac and medical unit and ICU in San Antonio. And we had a gentleman who had come in with an MI, a heart attack, and he was determined to pray 5 times a day. Well, you can imagine trying to meet that request with telemetry hookup, with an IV, and all the other accoutrements that come when you've had an MI and you're, being treated. So I kind of took this on as a project and went to the team and, to the nursing staff and said, 5 times a day might be a real challenge, but what can we do to help this man practice his faith that is so integral to his recovery? Because if he's not able to pray, what kind of outcome could he have? And they all really had to stop and go, wait a minute. I mean, one person on the team, I clearly remember them saying, "So Elaine, what you're asking is we need to help him get down on the floor and pray." And I looked at this person and said, "Yes, I'd like us to look at how we can make that happen, because it's not him just praying in bed. It is the entire act of how he prays 5 times a day." So as you can imagine, there were a lot of conversations. I might have, gotten some funny looks. But the staff really, really tried to make it work. And I was like, yay, yay. I'll take the win, just in trying to, again, acknowledge this man's faith, spirituality, and religious practices. And he did well. And whether it was him being able to practice his religious, practice his religious faith, or whether it was because, whatever medical interventions included a catheterization and stents, but he did really well. So again, where have you witnessed an individual's choices and care being influenced by their faith, religion, or spirituality? Let's look at suffering. It's hard to have this conversation about religion, faith, and spirituality without talking about suffering, everyone. So here are some different religious traditions and their beliefs on suffering. Just a reminder, a definition of suffering is a state of undergoing pain, distress, or hardship, and that a perception of suffering influences people's healthcare decisions. There may be an individual who believes that the suffering is meant to assist them, to make them more aware of their faith, religious, or spirituality journey. So when you look at some of these different beliefs and you're working with someone who may be a member of this religious community or religious practice, keep these in mind. It certainly could be part of their story. Well, by this time, you may be saying, Elaine, isn't spirituality and faith and religious practices, isn't that the job of the chaplain or their own, the person's own visiting clergy? Okay, true. But if your answer to addressing someone's struggle with their spirituality when they've received a cancer diagnosis, or they've been in a catastrophic accident, or they've been told you have a lifelong chronic illness, pick any of them. If your answer is, oh, I'll call the chaplain to see you. Okay. I hope you're fortunate in your organization or in your facility to have a religious support team, chaplains, pastoral care, because in a lot of organizations that may or may not be available as timely or as appropriately as some people may need. So of course, I'm asking all of you as my case management colleagues, let's step up. Let's be able to at least have an initial conversation about someone's spiritual practices. Spiritual support and a space for that reflection can support spiritual development. We need to be mindful that attention to spiritual issues is not just the work of our chaplains, pastoral care, or visiting clergy. So all members of the healthcare team need to be aware if an individual's spiritual practices do influence their healthcare decision-making, or how they approach their healthcare team, or even how or where they decide to choose to receive care. Another question I have that I'll throw out to all of you is, does spiritual care have a billing code? You know, does the chaplain have an RVU when he comes to see your patient in the hospital? There's certainly a nursing diagnosis called individuals experiencing spiritual distress. And I'd like there to be a Z code. So for those of you that are familiar with social determinants and social drivers, or already work for organizations that are obligated now under CMS, Medicare, and the Joint Commission to code or tag individuals with at least 2 of these Z codes. There are over 50 of them. There isn't one specifically for spiritual distress or spirituality. Ellen Fink-Samnick and I have had quite a discussion about this. And then when we're going to look at spirituality, you know, before your knee-jerk reaction to call the chaplain or the spiritual, the pastoral care, what could we do? So here's that next take-home message. I think I'm on number 3 or 4 by now, everyone. I'm going to offer you the FICA spiritual tool. I'm going to get a quick drink of water here. So the FICA tool is one that's been around for a few decades from George Washington University. There is a reference for it on my list at the end of these slides. But this is how to guide the conversation. Now, in Elaine's opinion, so again, this is a little subjective. In my opinion, I think FICA is a great mnemonic to remind us of areas that we might discuss with somebody. But this tool is full of closed-ended questions. You know, those yes, no's. And it's easy for people to answer yes or no just to get you out of their room. I know I've experienced that one, and not just in spirituality, but for lots of other things. I call it being yes ma'amed. Some of my military members do it really well. We look at this FICA tool. F is faith, I is importance, C is community, and A is address and care. And you can see those sample questions. Well, if you take a look at them, most of them are all closed questions, except the last one. How would you like me to address these issues in your healthcare? So I'd encourage you to look at this as a guideline. And maybe in your organization, you have a spiritual assessment, particularly if you work with hospice, because it's a requirement. But for many of us, this may be at least a starting point or an outline, because it is more than checking that religious preference box. So how would you integrate a couple of spirituality questions into your case management assessment? Is it their religious background and faith preferences? How about appropriate resources? If they do want to see their own faith leader, clergy, you know, how can you make that happen? If the family is there, you know, can they put in a request for that visiting clergy? I would ask, how would you start that comprehensive and compassionate discussion? Because it is what matters to the individual. And if we're going to be effective, we've got to consider all those aspects, the whole health of the person. So it is bio, psycho, social, spiritual, cultural, etc. It's a really big wheel to consider. Back to spiritual wellness as I wrap up, and I think we're going to have some time for questions and answers. So when people have spiritual wellness and spiritual well-being, How do they feel? How does it look, for me or you? So here are some ideas. It certainly helps our resilience, everyone. And we know case managers need to be resilient. We have greater creativity and ingenuity. Case managers are innovative. And people do experience improved healing and recovery. Now, that said, we can all do better at our conversations about spirituality. And I know they're uncomfortable. Again, remember your grandmother, religion, sex, and politics, 3 topics you didn't discuss in polite company. Case managers, we get to talk about all kinds of things that our grandmothers would just be squeamish about. So why not explore spirituality with the individuals and families that you're working with? So consider those open-ended questions. And I've given you 3 more here. Ask, what gives you hope? What gives you meaning in your life? What brings you peace? These are very general questions, everybody, no matter an individual's religion, faith, or spirituality. Be that advocate or champion on your healthcare team, like I was for that gentleman who was a practicing Muslim and wanting to pray 5 times a day. Respect a person's individual spiritual practices. This is part of inclusive healthcare. It is holistic healthcare. And ensure that the healthcare that the person is receiving doesn't violate their spiritual practices. So with that, I'm going to wrap up. Here are the references. I know I'm zipping through them, everyone, but they are on your handout. And a great big thank you to all of you for your time and attention. And June and Maureen, I'll open it up for questions, please.
Thank you very much, Elaine. What a very insightful and important presentation. We do have comments in the chat, and one was, thank you, Elaine, for, oh, it just jumped. You know how that goes. Thank you, Elaine, for addressing faith and spirituality as part of the person-centered care plan. And then another one was excellent information. We certainly need to self-reflect to be able to best meet our patients' spiritual needs. Some thank yous, yeah, and more thank you. So thank you for that. Let me check the Q&A. I didn't see any questions, but oh yes, there was a lengthy comment in the chat about Jehovah Witnesses.
Yes, ma'am, I see that.
Yeah.
Someone whose name begins with K, initials KO, shared with everybody her experience with the Jehovah Witness. I'd encourage everyone to just read this quickly because this person, this case manager, comments that they really needed to ask about spiritual considerations and talking about a DNR. Again, we recognize that these are tough, hard conversations, folks, but I'm so hoping that this session this morning gave you a little more information, some tools, some takeaways, so that you could start to have the conversation. Is there anything else this morning, June?
Well, the only thing I was going to say, so on this one comment, the case managers or healthcare professional, says that she had to basically teach the team, what the parameters were for Jehovah Witness. So, I mean, just to bring that up. And then I just thought, just to tie, in a way, tie the last lecture together with yours, that I know in my own experiences, really being a detective and solve the problem of a complex case, that I always have on my list, the spirituality or the religious following of a patient, and if they are tied to a religious community. Because, and I don't know if you want to address that, because in my experience, that if they are, then that's a resource for case management to see if we can tie into them.
Absolutely. Absolutely. And thanks for mentioning that. Again, everybody, when you think about resources and assets, particularly for our individuals who are underinsured or uninsured, our faith communities, religious organizations are, I'm about to say, like just a wealth of
Right.
donor closets and soup kitchens and uh, clothing, mental health support. I spent a few years as a faith-based nurse in my church. And some faith communities actually have a faith-based nurse as a paid position. So please remember, if you are struggling looking for equipment, clothing, food, transportation, friendly visitors,
Mm-hmm.
all kinds of things. A person's faith community may be a source, but I've used faith communities for those resources for individuals who weren't members. And, that brings me back to 23% of Americans are unaffiliated. But many of these faith organizations are there to serve their community, not just if you're a member. So that's an excellent reminder, June. Thanks so much.
Was always on my list, is like, what do I have in my back pocket? Like one of the
Yeah.
almost, right? And at the one time in a really tough case, I used the faith community, and they rallied the whole community. So really the amount of, support that you can get it is quite huge. So thanks so much, Elaine. It was a really important, valuable lecture.
You're very welcome. And everyone, my contact information is on that thank you slide. So if you'd like to reach out with me, have more conversation, share ideas, again, this is one of the 3 areas that as a case manager, I'm really passionate about: spirituality, food insecurity, and military veteran issues. So I would love to hear from everyone. I appreciate the invitation from the Case Manager Society of New England. Enjoy the rest of the conference, everyone.
Thank you
Bye-bye.
too.
Thank you,
Bye.
Elaine. Thank you, Sarah. So our next session, as I said earlier, is our last, assessing your client's capacity for informed decision-making. I have the pleasure of introducing Dr. Rebecca Werschba. She is the founder of Boston Metro Neuropsychology. She earned her doctorate in clinical psychology at Arizona State University and completed her internship in Tucson, Virginia Hospital. Her postdoctoral training in UMass Medical Center involved assessment of patients across the lifespan, from children to geriatrics, with neurological concerns, including dementia disorders, movement disorders, epilepsy, brain tumors, ADHD, and learning disorders. Dr. Werschba additionally completed an advanced postdoctoral fellowship at MGH within the home-based program, focusing on patients with mild traumatic brain injury and often comorbid substance use abuse or mood disorders. She has specialized training in evaluations of capacity and competency in older adults. Dr. Werschba, would you please join us?
Hi. Thank you for that introduction. I'm going to see if I can figure out how to share my slides. So if this doesn't happen in the next 5 seconds, please let me know. Let's see, technology. Are we working? Is it playing? Play. Hey, I think we've got it going. All right. Thanks so much for the introduction. As you say, I'm the founder of Boston Metro Neuropsychology. Primarily what we do at Boston Metro Neuropsychology is work with older adults when there is some sort of concern about cognitive changes. So most often that means that we're working with people where there's a question of dementia. There's a lot of reasons why people can notice problems with memory or changes in their thinking. In addition to Alzheimer's disease, there's normal aging and other things that can impact a person's ability to think. So primarily, so that's also to give you a little bit of context that that's going to be one of the kind of directions I'm coming from. There's a lot of things that can impact a person's capacity, and we'll be talking about that as well. So most of my knowledge is going to come from capacity for people where there might be some change over time. So normally, again, my group usually does dementia evaluations. Part of that can be looking at a person's capacity to make decisions. So there's a lot of reasons why people might lack capacity. I'm, again, generally coming at from the question of, does this person have some sort of dementia that could cause them to no longer have these abilities? But you might see people who have substance use issues or people who have developmental disabilities or psychiatric illnesses that could cause them to no longer be able to make decisions. So most of what I'll be talking about, again, will be kind of from the point of view of looking at older adults, but this should work for everybody. Let's see. All right. So I'm going to start off by talking about an example of a patient. So this is your client, Mr. Jones. Mr. Jones has come in to see you. He's 85 years old. He's got 4 kids. He's living with his youngest son, John. So Mr. Jones has been diagnosed with lung cancer and he's refusing chemotherapy. He believes that he's going to be cured through prayer and clean living. John, the son that lives with him, wants him to be treated medically, even if it's against his father's will. So does Mr. Jones have the capacity to refuse treatment? So this is an example of the kind of person who might come in or the person who you might be seeing where there's really some question, where there's different people who have different perspectives and a lot of different things that could affect this person's ability to make a decision. We'll be learning about some of those and we're going to come back to Mr. Jones at the end. So let's talk about what capacity means. To start off, anytime we're doing any sort of assessment, we're going to be thinking about the ethical principles that underlie the decisions that we make. So first of all, we need to be thinking about autonomy, and this is absolutely going to underlie any decision that we're trying to help people make about whether a person has the capacity to make their own decisions. So we want to respect an individual's right to make their own decisions and choices. People will come to see you with different perspectives, different thoughts. I'm sure that everybody has worked with people where you just don't agree with where they're coming from. But we're starting off with the assumption that everybody has that right, and we're starting off with the assumption that everybody has that ability. If we're trying to say that a person might lack capacity, we really need to make a case for that. So we're not starting off with the idea that, we want to make somebody the healthiest that they can be. We're not starting off with the idea that we know what's best for them. We're starting off from the perspective that they have autonomy, that they have capacity and the ability to make their own decisions and choices. Again, if there's a question about that, we need to make a really good case for that. At the same time, beneficence is one of the things we're working towards. We want to promote and maximize well-being while minimizing harm. The flip side of that being non-maleficence, we want to avoid actions that could cause harm or inflict suffering. These are all things that are going to be very careful that when we're trying to balance these things, when we're making a decision, when we're trying to help somebody make a decision about capacity. Because at times, they may not be making decisions that seem like they're in their best interest, and we want to respect that. We also want to make sure that people aren't coming to harm. And justice is also important. We want to be treating all individuals fairly and equitably, regardless of their backgrounds or characteristics. It may be most of us have some we may make decisions or thoughts about somebody based on their background. And this could be their socioeconomic status. This could be, have they been using drugs or alcohol? This could be racial characteristics. These might be things that, whether we know it or not, may be changing the way that we think about things. And we need to be thinking about that. That needs to be something that that is on our mind. We need to be aware and cognizant of the fact that we're not just ignoring these things. We're not just saying, okay, well, let's pretend that everybody's equal. We're not. We need to know that most of us are going to have thoughts that may make us say, oh, well, they've been using drugs their whole life. They can't make their own decisions. We're going to help them out. That's not justice. We need to come at it as fairly and equitably as we can. And confidentiality, of course, is one of the biggest things that we all in the healthcare system are very familiar with, respecting privacy and keeping information confidential. And that may mean that, again, even if you think that, you want to be drawing other people into, a person's care, you need to be still thinking about confidentiality. You need to still be respecting their privacy unless, again, there's adequate reason to be bringing other people into it. Again, hopefully we have people's permission to do that, but otherwise we're going to be, are they at harm for themselves or others, and not just harm. Are they going to kill themselves? Are they going to harm or kill other people? Or are they a vulnerable adult or a child that could be caused to harm? Those, of course, are reasons why you may need to break confidentiality. So when we talk about capacity is different from competency. And that's important because competency is, I think, the word that people use a lot. Is this person competent? So I, as a neuropsychologist, have gotten that question sometimes when I see a patient. They'll say, hey, is this person competent? Well, competent doesn't really mean a whole lot. Competence is actually more of a question of, does this person have a capacity to make decisions? If somebody says competency, I go back to them and I say, hey, I need you to actually break that down a little bit. What are you asking me? What sort of capacity question are you asking me? Because a person may have the capacity to make one decision, but not another. Or they may have elements of capacity. They may be able to do some aspects of something, but not others. And they may be able to, again, have capacity to make decisions with some help. So it's usually not a black or white thing. There's never a time that I can just say, hey, this person is or is not competent. There are at least 5 different kinds of competency that we may be thinking about. And again, they are different and have different standards. So there's testamentary capacity, the ability to make a will. Are you able to understand what you have? Are you able to understand who will benefit from whatever will you might make? There's contractual capacity, being able to understand any sort of contract or agreement or business decision. There's donative capacity, being able to understand gifts that you're giving, the nature and extent of whatever gift you are giving. Medical decision capacity, which I assume is going to be coming up for a lot of you, which is, can a person make their own medical decisions? Can they agree to or decline treatment? And financial capacity, can they manage their own financial affairs? Again, there are actually different standards for a lot of these. For example, the standard to be able to enter a contract is actually higher than the standard to change your will. Because if you're making a decision that's going to affect you while you're alive, we want to make absolutely sure that you have capacity, that you're not giving away money that you need right now. Whereas a will may have a slightly lower kind of level of what you need to be able to prove to be able to make those kinds of decisions. And even something like financial capacity may be broken up into different things. A person may have the capacity to make larger decisions. What do I want to do with the land that I own? Should we buy a new stove? But they may not be able to manage their own checkbook. So all of these things, again, this is to say why capacity is actually a much more specific question. And if we're asking, does somebody have this capacity, we can usually break it up into smaller pieces. So what is undue influence? This is something that comes up a lot when we're talking about financial capacity. So one of the reasons why somebody might see a neuropsychologist or somebody like me is because they have a question about whether their parent, whether their friend can make a decision to, say, change their will, give a gift. And there's a question about, well, is there anybody who's acting on this person to make them make a decision that would not be in their best interest when they don't have capacity? So this is when a person is induced to act other than by their own free will or without the adequate attention to the consequences. The time you might see something like this is if instead of John having a question about, or not John, John's father, Mr. Smith, the question might not be, can Mr. Smith make a decision about lung cancer medication? The question might be, what if Mr. Smith wanted to suddenly change his will and leave everything to John? The other kids might have something to say about that. So what they'd want to look at are the susceptibility factors of the victim. What are some things? And we'll talk more about that. But are there factors of the victim that could make it less likely that they can make their own decisions in an informed manner? Is there anything about them that might keep them from being able to make the kind of a decision that they might have maybe once made if they didn't have something that would have affected their capacity? Is there a confidential and trusting relationship between the victim and perpetrator? Is this person, trying to keep them from being around other people? Is John kind of pushing away the other kids? Is John saying, hey, they're kind of out to get you. I'm going to help you out. Talk to me. Don't talk to them. Is there an active procurement of legal or financial transactions by the perpetrator? And is there a monetary loss to the victim? So these are things we're going to be looking at, in general when we're thinking about financial capacity. But undue influence can also come up in other ways because unfortunately questions about guardianship or medical capacity aren't always, completely different from questions of financial capacity. In a worst case scenario, is there any concern that the undue influence, the person who might be influencing your patient, might they not want the person to get their best medical care? Might they be trying to move them to, hey, they don't even need to go to a facility. They should just stay here with me. I'll take care of them. Are we concerned that there may be some financial abuse as well? So what can influence capacity or susceptibility? There's a lot of things. So there's cognitive factors. Attention, memory, speech, comprehension, orientation, things like that. Has the person declined cognitively? Are there cognitive changes that can really keep a person from being able to make the kinds of decisions that they might have? A person may be susceptible if they have some sort of dementing disorder, if they've had a stroke, if they've had a traumatic brain injury. That can affect their speech or their memory or their ability to focus and pay attention. Has it affected their executive functioning, the kind of, higher level ability to make decisions? Emotional factors can certainly influence capacity or susceptibility. If a person is depressed or anxious, they may not be able to kind of summon the ability to make decisions or to care about what's happening to them day to day. One of the things that I'm often asked about when I'm doing an evaluation for dementia is this dementia or is it pseudo-dementia, which isn't a term that I use a whole lot, but basically, are there other factors that can actually make this person look like they have dementia? And often when they talk about pseudo-dementia, they're asking, is this person's depression making them look like they have dementia? So a depressed person may not be able to make decisions that they would have made before. They may not be able to make informed decisions. And it may also make them more susceptible to undue influence. There's also behavioral factors, hallucinations, delusions, paranoia, disinhibition, things that can come from drugs, alcohol, dementia, even lack of sleep, medications or medication effects can influence that as well. So when we're trying to make decisions about capacity, when we're trying to decide whether there's any undue influence, when we're trying to decide whether a person has capacity, we want to be looking at what factors may be affecting. They're maybe affecting them right now, which also might give us an idea about, well, what can we play with? What can we help before we make a decision? So if you're screening somebody, and by the way, this is the worst AI photo. I don't know why I put it in there. I thought about taking it out, but it was too funny. And I decided that if you guys were bored at this point, you can look at it and try to figure out what's wrong with it. It's pretty freaky. But tips for screening. If you are working with somebody and you're trying to decide, does this person likely have capacity? The first thing you're going to want to do, if you can, is talk to a client alone. I've had patients who came in to see me where the doctor said, hey, I think that they're basically fine. Their memory might be a little off. Their son says they have some memory problems, but they're basically fine. And when I came in to see them, once I got them alone, it was clear that actually they were severely demented, but their son had been speaking for them out of love. There was no intent to deceive. But they were taking the son's word for it that their father had some memory problems, where in actuality, he could maybe at best follow simple directions, like, sit down if somebody pushed him in. Talking to a client alone will give you a really good sense of what the person's abilities may actually be. As well as, if there is any concern about undue influence, that can be helpful too. You want to make sure that the person who may be influencing them isn't speaking for them. A lot of times, especially when we work with older people, there may be kind of a pull to just take the adult child's word for it. Their son or daughter loves them, they want to help them out. And that's great. But a lot of the time that might kind of obfuscate what's actually happening with a person's cognitive abilities, with their ability to understand their own decisions, if a family member is speaking for them. Similarly, you want to meet with them more than once. You've probably had times where you speak to somebody at one point and they seem kind of fuzzy or out of it, and then you might talk with them another time, and they might really, be on the ball at that point. You're probably familiar with sundowning if you've worked with older adults, where later in the day, they might get a lot foggier. They might have a harder time thinking. Lots of times, I almost exclusively work with my older adults in the morning because that's usually when they're best. But you want to get a sense of how they're doing at different times. There's also some dementias that can affect people and cause their ability to attend or to focus. It may cause that to wax and wane. There may be times that they're extremely capable of making decisions and other times that they're very much not. And it's helpful to know that. When you're working with somebody, you should speak slowly and clearly. A lot of times I've seen people where there was a concern for dementia where actually the person was just a little bit deaf. You want to make sure that they can hear you and understand you. In fact, it's a really good idea when you're talking with somebody and you want to make sure they understand you, have them repeat it back in their own words. That makes sure that, first of all, they can hear you, that they can focus and pay attention. And as well as the fact that if somebody repeats something back in their own words, that can actually help them consolidate that and kind of move it into their memory center. So that's a really good way to, it's important to make sure that they can understand. It's also important if you're trying to get a sense of, hey, can they remember things? Make sure that they get it into their brain. And of course, minimize background noise. Again, because of people who are hard of hearing, but also people who have trouble focusing. That's helpful. So screening for capacity, what are you going to want to ask them? First of all, are they oriented? I always start off just by asking somebody the date. And I don't care if they know the actual date. Honestly, I don't know the actual date right now. It's the end of September. I'm pretty sure end of September. 20th, 21st, something like that. 21st. I would call that close enough. But if somebody says that it's March, if somebody's off by a month or two, and if they tell you that it's, 1996, if they can't even make a guess, well, then we probably have a problem. Most of the people that I work with don't know the exact date, but they have a sense of what's happening around them. Hey, what holidays have happened recently? What's coming up for you? Who's the president? Or if you don't follow politics, like tell me something that's happening in the world. We want to know that they are basically, are they with it right now? And do they have the ability? That's also a great way to find out, do they have the ability to form memories? Can they appreciate the situation and the consequences? So Mr. Jones has lung cancer. Mr. Smith has lung cancer. Does he know what that means? Does he understand the risks and the pros and the cons? Is that what's next? Yeah. Can they understand the pros and the cons of making some sort of decision? If this is a financial capacity question, do they understand that if they change their will in favor of their son, John, do they understand that, boy, it's going to make the other siblings really unhappy? Or are they surprised when they find out about that? Can they understand everything that goes into the decision that they're making? Can they explain their reasoning? We're going to talk about this a lot more at length, but we don't have to necessarily like their choice. But we need to know that they can understand, that they can explain, here's the reason why I'm making that decision. Even if we don't like it, is there some sort of logical pull to why they're doing it? Even if their reasoning is, hey, this is just something that's important to me. Or their reasoning is, like, yeah, it's going to make my other kids unhappy, but John has been with me, and actually over the past 20 years, he's been the only person to check on me. Can they explain it? Are they informed? The pros and the cons again. And is their decision consistent with their values? This is going to be a huge one when we're looking at capacity, and sometimes this can be a difficult one for us to answer without, in some sort of brief screening. But what, if they're suddenly saying, I'm going to give all of my money away to charity, like, probably we don't love that. But do they have a history of following a particular charity and giving them money? Have they always said, hey, I'm going to, give my money to charity. This is something that's important to me. What do we know about the things that are important to them? Because it's possible that a person's cognitive abilities may change, but their values may still be there. And if we think, hey, I don't know if cognitively they have the capacity to make a decision, but is the decision they're making, does it seem very much like something they probably would have made 5 years ago or 10 years ago, prior to any potential change in capacity? And there's different ways of kind of getting a sense of values, talking to with permission, talking to family members or other informants, trying to get a sense of, again, how these things have followed them through time, to try to get a sense, again, of what's important to them. Does this decision seem consistent? So what doesn't automatically imply a lack of capacity? So the first one is cognitive impairment. You can be cognitively impaired and still have capacity. Just like you can have mild cognitive impairment and still drive, which I don't love, you can certainly have mild cognitive impairment and still be able to make decisions that are important to you. Most people still know who they're, and this is a matter of degrees. This is never a yes or a no. But even somebody who has cognitive impairment, even early Alzheimer's potentially, they may know who their family is, and they may be able to make certain decisions that are, again, consistent with their values. They may be able to, make certain financial decisions, even if not others. So this is kind of one thing to put into our decisions when we're trying to make them. And of course, decisions that we don't agree with, even if they are objectively bad decisions. If you're working with somebody and they decide that they want to keep drinking, even though they have liver failure, like that's a really bad decision. And there's no doctor that's going to like that. And it would be really, you know, there might be some pull to say, well, you can't make that decision. But this person might say, look, you know, I'm informed. I know this is bad for me. Like, I know that this is going to kill me, probably. I know that this is terrible for my liver. I know that the best thing for me to do would be to quit. And I don't want to. I really like drinking. Drinking makes me feel good. So they're informed. They're informed and they're making an informed decision. Now, there may be other reasons why they may lack the capacity to make a decision like that. But just because it's a bad decision, just because we don't like the fact that they're saying, hey, I'm going to check myself out and go home. You know, I'll have the neighbor check on me every once in a while. If they can name those pros and cons, if it's clear that they're coming at it with the information that they would need to make a decision, just because it's a bad decision doesn't mean that they're not allowed to make a bad decision. We're all allowed to make we've all, I'm sure, made bad decisions, and people have told us they're bad decisions, but we're allowed to make them. And again, we're starting with the assumption that people are coming in with capacity. We start off that way. We need to make a really good argument for why they wouldn't have capacity before we kind of lean in that direction. So just to talk about neuropsychology for just a moment, you know, where we might come in. Neuropsychology, I'm a neuropsychologist, and we're the intersection between neurology and psychology. We look at how factors in the brain, how somebody's mood, how somebody's behavior, how their environment may contribute to cognitive problems or cognitive changes. So we look for the etiology, you know, what has caused these changes, including the etiology of psychological problems. We look for how the cognitive and psychological problems may relate to each other. We are psychologists first. So even though we're there to do, you know, you might have sent people for testing. We're not computers, we're not AI. We're psychologists, because the way that somebody does on tests is really impacted by what's happening in their world and what's happening in the way that they're able to. Are they able to focus and attend? Are they able to, you know, how is their mood? You know, do they have cognitive problems? But when I'm talking with them, does it turn out that actually, you know, they've got untreated sleep apnea? When I'm talking with them, do I find out that when they say they have 2 drinks of wine a day, you know, each drink of wine is actually like this, and actually it's more like a bottle of wine? We're psychologists. And what we do is we try to get a sense of, hey, what's going on with somebody, which is one of the reasons why we might be called on to make some to help address the question of capacity. So briefly, we look at a lot of different things. If you send somebody for a neuropsychological evaluation, we're probably looking at their attention, their processing speed, their visual spatial functioning, how do they understand the things that they see, their executive functioning, which can include decision making, but also pattern formation, and kind of higher order thinking. Verbal memory, I have that one starred because verbal memory is my bread and butter. That's what we use most of the time to try to make some determinations or to try to help understand whether a person has any sort of a dementia. Their visual memory, which is also important, and emotional functioning. And we look at all of these things for everybody. Even if you send them in for just memory problems, I'm going to be looking at all of these things because, again, there's more than one reason why a person could have memory problems. You know, if I'm talking to you right now and, you know, you're real focused, like, boy, you are just, this is the most fascinating thing you've ever heard. And then tomorrow you can't answer a thing about capacity. Maybe I'm worried you have a memory problem. On the other hand, if this is your lunch hour, and you're doing this by Zoom, so your kids are in the other room, and also, you know, you're on your phone, like, cool, but you're sort of listening, and tomorrow you can't remember what capacity is. Maybe you don't have a memory problem. Maybe that was an attentional issue. We also look at all of these things because I'm always interested in patterns. Maybe your memory is poor, but maybe everything's poor. And that's going to be a different sort of cognitive profile than if I'm looking at somebody who has, you know, pretty good visual spatial functioning, their attention's good, but their memory is bad and their language is bad. This briefly is just an example of how Alzheimer's disease may look different from a vascular dementia profile, where for Alzheimer's disease, the first thing that says memory is just like, can you repeat a story? Can you repeat some words? But the delayed memory is 20 minutes later, oh boy, we've got a problem. So we really want to look at all of those things. I talk about mild cognitive impairment versus dementia. So mild cognitive impairment is any change that's greater than expected for normal aging. So anybody who's in their 40s or higher they probably noticed that their memory is just not what it was. And boy, you might be having some problems coming up with the right words sometimes, kind of fishing for stuff. Maybe you walk into a room and you open your refrigerator and you're like, why am I here? Why did I open the refrigerator? What was I doing? And then you find the mustard and you're like, oh, right, I was making a turkey sandwich. That's normal because unfortunately our brains start to age just like our bodies start to age. And that stinks, but it is normal and expected. If I'm looking at mild cognitive impairment, I'm looking at changes in functioning that are greater than expected for normal aging. So it's not just that you're walking into a room and you don't remember why you did it, but now also, you're forgetting that you went out with somebody the day before. And when somebody reminds you about it, it doesn't really come back. But still, they don't really interfere. Mild cognitive impairment, it still doesn't really interfere with independent ability, the independent activities of daily living. You're still probably driving. You might still be working. You're still socializing. You're cooking. You're cleaning. You might leave the stove on. I mean, that's not great, but that might happen. But you're still basically doing the things that are important to you. Some percentage of people with MCI are going to transition over the course of a year or 5 years to dementia. So this is progressive decline in cognitive functioning or behavior. And it does affect your IADLs. Maybe you can't drive anymore. Maybe you can't operate a stove or a microwave. Maybe you're no longer going out with friends or family because you can't, maybe because you're embarrassed or you can't come up with the words and it's just too stressful now. And this is caused by brain illness. This is important to know because it's more likely that a person with MCI will be able to still retain capacity, more likely that they'll retain capacity. And more likely, we're still kind of in an in-between area where we're saying, hey, this could get worse, or it could get better, or it could stay the same. If we're calling it dementia, then it's likely that it's not going to stay the same. It's likely that it's going to be getting worse over time. Very important when we're talking about capacity, because capacity, again, may not be black and white. You might be saying this person doesn't have capacity to make a decision right now, but they might later. A person who's hospitalized with a UTI may not, they might be hallucinating and delusional, absolutely unable to make their own medical decisions. But give them a few weeks, give them a few months, and it is likely that they'll go back to something like normal, or at least that they may improve to the point that they again have capacity. If we're talking about a progressive decline, once they lose capacity, it is likely that that capacity is gone. So different kinds of dementia. There's Alzheimer's disease, which is the most common kind of dementia that we're looking at. This is primarily going to affect memory and language, at least to start. All of these are going to, especially Alzheimer's disease, frontotemporal dementia, and Lewy body dementia, they are going to get worse. And eventually they're going to affect everything in the brain. But where it's going to start with Alzheimer's disease, of course, is going to be memory and also word finding. Vascular dementia is actually a little trickier because it doesn't necessarily get worse in kind of a progressive manner. Frontotemporal dementia is a particularly tricky one because it will often hit people younger, maybe starting as early as the 40s or 50s. With two different variants, and one of them you might be seeing people where they just start behaving really weirdly. and really inappropriately, something that's very different from their normal self. And that would be a behavioral type of frontotemporal dementia. Or they might start having language issues, not like the issues that we're all having starting in their 40s where you can't remember a single word, but now suddenly you can't communicate well, or you can't pronounce words anymore. And it's very unusual and different. Also will get worse over time. And Lewy body dementia, which you will more likely see, you may see that fluctuating attention and abilities. One day or 1 hour, they might have some real problems, and other times they might, again, be much more with it. They may also have hallucinations and delusions. The delusions often related to their hallucinations. It's important to know what kind of dementia you're looking at if you're trying to think about capacity. Because, for example, somebody with Lewy body dementia, if they want to make a financial decision, they may actually have capacity at 10 a.m., but not have it at noon. If you're looking at capacity for frontotemporal dementia, you might be looking at somebody who has their memory is fine, to the average person. If they just meet them, they look fine. But if they have that diagnosis, the likelihood is that they cannot make good decisions because their brain is very deeply impacted. Their frontal lobe, is in a lot of trouble. And they may not have capacity, even if they can talk with you. And even if, on in a casual conversation, they seem fine, they're not fine. Dementia mimics are also super important to be looking at if you're trying to make some decisions. So delirium is that temporary change in cognitive functioning due to metabolic or infectious disturbances or the effects of drugs. This is going to be characterized by disorientation and these changes from baseline that are going to be pretty extreme. Be on guard if you're working with somebody who was diagnosed with dementia during a hospitalization or immediately afterwards. It's tricky because a lot of times, that's often somebody who has been, having a slow decline into dementia. It may not really kind of come out until they've been hospitalized. But the flip side of it is that sometimes people are hospitalized due to an IUD or due to some sort of infection because they haven't been, maybe they weren't eating or drinking right. They're hospitalized. They are diagnosed with dementia because that's very much how they look. But then once they're fed, once we're making sure that they're hydrated, once their UTI is treated, they look fine again. I've had somebody come into my office with paperwork, with a folder and say, I wanted this evaluation because I've been diagnosed with Alzheimer's disease and I don't think I have it. And I was like, I'm already a little bit convinced. Let's talk more. And they were diagnosed while they were hospitalized. And they were declared that they lacked capacity. And of course, I had permission to do this evaluation, which I now needed because they didn't have capacity. So be very careful or cautious if you're trying to make decisions when they might be under kind of the immediate effects of a delirium. Pseudodementia is also something that we, again, it's not a term I think that we usually use now, but a lot of people still use it, which is a dementia or something that looks like a dementia due to a mood disturbance. So again, this is tricky. It's almost never kind of a black and white thing because many times we'll see somebody decompensate severely after the death of a spouse. And sometimes that's because their mood becomes so poor because of grief or because of depression that they really can't, they can't make good decisions. They look like they have dementia. The tricky thing is that a lot of times people do have dementia, but their spouse is holding them together. Their spouse actually did the cooking. Their spouse, would kind of instruct them like, all right, now it's time for you to go to this appointment. Now it's time for dinner. And people think the spouse, they think that somebody's okay, and then the spouse passes away and suddenly they're disoriented. So it could uncover a dementia, but it is also possible that depression or mood is causing these cognitive changes. And so that's something to be thoughtful about. Because in the case, again, of pseudodementia, this person If their mood is treated effectively through medication, through therapy, through a combination of things, they may get, they may become cognitively functioning well again. They may get capacity if they were lacking capacity again. So what do I do with an assessment? I'll kind of breeze through these just so you know what you're doing. If you send somebody to me or somebody like me, just so you know what we're doing here, and so you can read our reports. The first thing we do, and probably the most important thing we do, is we get a really good history, because I want to know all of those things. I want to know their demographics. I want to know, hey, were they a good student, or did they have a lot of problems? Were they, is there a concern about an intellectual disability, which would have, affect their ability to make decisions throughout their life? I want to know their medical history. Are they sleeping? Because boy, does sleep apnea just kick people in the teeth. And like a third maybe of the people that I see have sleep apnea, and a lot of them are untreated or undertreated. What's their medical history that could be impacting their cognitive abilities? What am I seeing on MRI? What medications are they using? And is there a chance that their medications are affecting their ability to make good decisions? If you're, working with somebody and you're not sure, what kind of decisions they can make, you also might want to take a look at their meds and see whether somebody has just drugged them to the gills. You've probably noticed that some of your patients or clients, if one of your jobs is to look at medications or to track them, that a lot of times people have medications added but not taken away. So somebody is given a medication for a problem that they had in their 40s, and now they're just on that medication. So, maybe it's an antidepressant during a time that, during a divorce or, a stressor, they're put on an antidepressant, and now they're still on the same antidepressant 30 years later. But now they're 70, now they're 80. The medication is certainly affecting them differently, and they might not need it. So you might end up with somebody who's on like 8 or 10 medications, and these medications don't always play well together. I want to know about their psychological functioning. I want to know about what's helping them. I want to know about their mood. I want to know what they're doing kind of day to day. I want to know about their family history, because sometimes disorders, both psychological and cognitive, can be hereditary. I want to know what they're drinking. I want to know what they're smoking, because obviously that can affect them. And again, if I ask them how much they're drinking, I want to know how much they're really drinking. I never trust somebody who says that they're drinking 2 drinks. I always ask them, tell me what a drink is. Are we having a glass of whiskey, or like a glass, are you having a tumbler of whiskey with like ice and then you fill it up? Like, that is not one drink. And their social functioning. Who are they living with? What are they doing day to day? What does their day look like? This is where I get the bulk of my history. The bulk of my assessment is actually, in a lot of kind of where I'm coming from in context, comes from this really good history that I can use to base all the rest of my information on. My behavioral observations, how do they look in the room with me? Are they disinhibited? Are they rude? Are they depressed? Are they kind of looking everywhere but not at me? When they come in, do they have a tremor? Do they have any facial droop? And all of this is helpful, again, for like later diagnosis. Really important for me to know psychologically how they're doing, their attention, and any other, again, thing that might make me say, hey, do they have a motor disturbance that could be important, diagnostically. So then I do my testing. I want to know pre-morbidly how they're doing. What's their education level? What's their occupation? I find that out by asking questions that seem like they have absolutely no relevance to anything. I'll ask people trivia questions like, what's the capital of France? I'll ask them to read words out loud. I'll ask them to define words. This is only important because I want to know, hey, if things like knowing trivia, things like being able to read words, those stay pretty consistent over time. You can start to have cognitive changes. You can have the start of a dementia, but your ability to read words will stay kind of the same. Your knowledge of, the World War II will stay pretty much the same. So if you were really good at word reading, I'm going to assume, okay, beforehand, you probably knew a lot of stuff. So I might expect the rest of your skills to be pretty good as well. If you come in and you didn't have a lot of education, and again, there's all sorts of socioeconomic things that go into this, like, boy, we need to be real cautious about it. This is not perfect. But it helps us know if somebody wasn't able to get far in school, if they were held back a lot, if they can't, if it's clear that their education didn't really stick, I might not expect them to do as well on the rest of my tests. So this just gives me like some context, some idea. It's not perfect. I'm not married to it. I look at their attention and working memory. What can you hold and manipulate in your mind? Can you repeat numbers back and forth? Can you do mental arithmetic? Can you focus? Can your brain hold on to information and move it around in your head? And this will vary dramatically for different kinds of cognitive problems. It may not affect Alzheimer's at all, at least early on. But if you have vascular problems, boy, you could really be in trouble with this. I look at how quickly you can do things, how quickly your brain can work. Can you substitute digits and symbols? Perceptual reasoning. Can you look at this and copy it? That's real tough. This isn't the best test because your approach to this might affect it. But can you see this and understand it? Going to be really important if there's a question about whether you can drive or not. But there's other tests I would do as well. Which direction is this line pointing? I look at your language skills, name words that start with a certain letter. What is this a picture of? That can vary dramatically by different dementias. In Alzheimer's disease, especially, language is one of the first things that's hit. You might not notice it talking to somebody, but it becomes pretty evident with the testing. I look at your verbal memory. Boy, again, this is the big one. This is the one that is affected in most dementias that we're looking for. This is also going to be incredibly important when we're trying to figure out whether a person has capacity. Because I tested by reading them a story and telling them to say it back, and then 20 minutes later, say it to me again. I want to see whether you lose information over time, whether you hold on to it, whether you can't get that info in the first place. I read you word lists. So important, because if you're told something, about your lung cancer, are you going to hold on to that information? If there's a question about, hey, can you go home and take care of yourself? Are you going to be able to remember that you have a disease? Are you going to be able to remember how to use the medication? Maybe you can go home with support if somebody's taking care of that for you, but what if you're going to refuse support? And you're not able to recall things moment to moment. So this is my heavy hitter and probably the most important of all the domains that I assess. This is going to be tied very closely to orientation. Most of the time when somebody is not oriented, they don't know the year, they can't name the president. Usually their verbal memory is quite poor. I also look at visual memory. It's just kind of a nice, hey, let's look at that next to the verbal memory in case they have some sort of dementia that affects visual problems. I look at executive functioning, how, can you understand how things are similar in your head? Can you do pattern formation? Can you switch between two different things, a letter of the alphabet, and then count by 3? Something like that last one, which isn't the exact test I give. Something like that is actually huge. Can you switch between 2 different tasks? Huge for driving, huge for driving. If a ball rolls in front of you when you're driving, are you going to remember to take your foot off the gas and slam on the brake instead of slamming on the gas? I also look at physical functioning sometimes if there's any sort of question about seizures or, motor disease. I'll look at, how your manual dexterity. I'll look at your finger tapping ability. I'll look at your hand strength. A lot of times I look at this to see if there's a difference with the right and the left, especially if I'm concerned about a brain disease. I do mood testing. I'll give you questionnaires assessing anxiety and depression, or sometimes personality evaluations. This is super important, by the way. A lot of people, if you ask them how they're doing, they will say fine. And if you give them a questionnaire, Like, oh no, they've got some real problems, but they're just not going to tell you about it. So that questionnaire can be really important to get a good sense of how a person's actually doing. Conversely, sometimes I'll look at that questionnaire and they'll say they're fine. And, when I ask them, how are you doing? They'll say, well, things are okay. And I'll be like, really, tell me more about okay. And then it becomes clear that there really is a lot more mood disturbance than they might be able to acknowledge. So I always do a combination of both, a combination of questionnaires, just screeners. You all have the GAD, you've got the PHQ, things that are really, really fast and effective, just to give you that sort of like, where am I starting from in my conversation? I might also look at things like financial ability or knowledge if I'm doing if there's a question about financial capacity. Can they do simple math? Can they write a check, to Sunny's Electric Company? Do they know how to write a check? Do they know where that number goes? Maybe less important in the days of digital banking, but a lot of people still really like their checks. I also want to know, do they know what they have? I spoke with somebody who told me that their income was like $50,000 a month probably. And I was like, oh, break that down for me. This person did not have the capacity to make financial decisions, to change their will, to make big purchases. They didn't know what they had. So how can you make a decision, like a big decision, a big financial decision, without knowing what you have? I don't have a slide for this, wish I did, but I also give, depending on if there is a capacity question, something called a test of judgment. You walk into the house and the water is on and you can't turn it off. What are you going to do? Can they tell you what they would need to do? The house is on fire. What do you do? Like, do they think real hard about it, or do they say, "Oh, I'm going to call 911. I'm going to get out of the house"? You're traveling and you don't have your medication, what do you do? So kind of real life situations, are you able to make good decisions that show that you have a sense of what you should be doing? There's some really nice screeners that I recommend. So one for especially the assessment of older adults with diminished capacities. This is available for anybody, so y'all can just download this. And this is a nice little worksheet because capacity ultimately is a legal decision most of the time. And so the American Bar Association worked together with the American Psychological Association to help determine, whether a person may have capacity or not. And there's this worksheet that can help you get a sense of, hey, what are some of the signs and what are some ways that you can test whether they have these signs. So I strongly recommend people look into this. There's also a website, again, this is free, the Older Adult Nest Egg, which can be used for professionals or for the adults or for families and friends. And this is primarily for questions of financial capacity. Are they aware of what decision they're trying to make? Can they make, do they understand the decision? Why are they doing it? This can really help you dive deep, especially if you don't like the decision they're making. Can they explain it, even if you don't like it? So I use both of these tools when I'm looking at when I'm trying to determine capacity. So when do you need an outside expert? You don't usually need an outside expert. If somebody comes in and like it's clear that they're fine, they're oriented, you've spoken with them, they know what they're about, they can give you some pretty clear pros and cons. All right, you're representing them, they're representing themselves, they can make their decisions. There might be some mild capacity concerns, but you're not really sure, like, oh gosh, maybe their memory is not great, but they're still pretty with it. You might want to send them for an evaluation. If the capacity concerns are more than mild or they're substantial, even with supports, because supports are going to be important. Most of the time we want people to have family and friends who can support them. You might want to strongly consider professional consultation or formal assessment. Like, look, they just don't seem to have a whole lot of memory. They're not carrying things, over from one thing to the other. Like, we should probably get that checked out. On the other hand, sometimes it's just clear that that capacity is not there. It may be very clear that the person has very little comprehension. And comprehension is going to be the big one. If they can't comprehend, then they don't have, then they aren't going to have the capacity. So they even support isn't enough, or they lack support. In that case, that's where you might need to start thinking about, you know, legally, does this person may not have capacity. We may need to take this, you know, somewhere else. So if you're not sure whether there's capacity, you have options. You can get a consultation. So, you know, talk to a lawyer. So, you know, you might just say, hey, like you don't need to give any identifying information. You can just talk to the lawyer and say, hey, this is what I'm, you know, this is, or a doctor and say, hey, this is what I'm working with. Does this sound like something where I'm gonna need a formal assessment? Does it sound like a straight up no-go? That may be enough. You can also do a referral, so actually send them to a clinician for evaluation. You probably would need the client's consent for that. So, or a proxy or a guardian, and there may be a question about, well, what do I do if I'm not sure if they have capacity and they, you know, can they consent? And boy, that, believe it or not, is above my pay grade, because I have been asking other professionals about that for a really long time. When I've been doing financial capacity evaluations, for example, I've had people who want that evaluation, but then, you know, does this person have the capacity to make a decision to pay me money to do an evaluation? Really tricky. In a perfect world, the person wants it, the family wants it, or the family wants it and the client at least is able to say, yeah, no, I'm okay with this. And you can assume that capacity. Most of the time, again, we're starting with the assumption of capacity. It may or may not include a written report. It's cheaper if it doesn't. It's more involved if it does. You can refer to a physician, a geriatric psychologist, a neuropsychologist, neurologist, an assessment team. Some of these will be covered by insurance and some won't. So often, if you have a question about guardianship or medical capacity, most of the time you can say, hey, this sounds very much like it would be covered by insurance. This sounds like a medical question. Insurance should cover it. Financial capacity generally is not. That's a legal question. So usually you will be, you know, you would have to do that private pay for that. I'll go to I just saw a comment. That's such a great comment. And we'll talk about that again at the end because I'd love to talk about that more. It's a huge issue because if a person is, you know, we'll talk about that a little more at the end. So I do want to go back to Mr. Jones. Oh, it's Mr. Jones, not Mr. Smith. Mr. Jones, does he have the capacity to refuse treatment? Again, he's an 85-year-old father of 4 living with his youngest son, John. He's been diagnosed with lung cancer. He's refusing chemotherapy. He's going to be cured through prayer and clean living. John wants his father to be treated medically, even against his will. So let's talk about scenario 1. And here's where hopefully we're going to be able to get some polling in, because I'd love to hear your ideas. This is just going to be your impression of things, because there's not going to be of course, these aren't going to be just a yes or no, but just your impression in scenario 1. So Mr. Jones. He is oriented. He is aware of his condition and his recommended treatments. He knows he has lung cancer. He knows that the doctors think that he should be treated through radiation or chemotherapy. His history and values. He's been part of a religious organization since childhood that doesn't accept medical intervention. He has never gotten, surgery. He has never accepted a blood transfusion. He has never done anything aside from like maybe getting, maybe taking, no, he doesn't even take Tylenol. He does not do this. Cognitively, he saw a neuropsychologist, believe it or not, this man. He got a diagnosis of mild cognitive impairment due to problems with recall. He can't really remember things very well, but if you say, hey, actually the story was about, this guy and he did this thing, he's like, oh yeah, all right, he can remember a little bit more. His mood is mildly depressed, but he says that his faith is helpful. So does Mr. Jones have the capacity to refuse treatment? You're going to want to know more, but like off the top of your head, can we get a poll on this? I think we talked about maybe getting a poll. I don't know how polls work.
Trying to launch it.
Okay, we're launching a poll, and in the meantime, I'll look at some of these questions or thoughts. So yeah, okay, so this is exactly what we were talking about in the notes. So it is a huge problem if they're refusing to be evaluated and they don't have that support, or we don't have a guardian. This is where it becomes a legal issue. This is where the court can order a determination of whether this person has capacity. And they may call in a neuropsychologist to do this evaluation. So again, or a neuropsychologist maybe it can take a few months to get to us, which can be a problem. So lots of times you'll have like a care manager who will be called in to do that kind of initial assessment. And then again, if it's iffy, if it's in that like 2 or 3 out of that 1 to 4, then that's when you might need to get a neuropsychologist. And again, if they're just not sure, this is where it becomes a legal issue and the court can order an evaluation or not. I'm starting to think that we're not going to get that poll, and it's not going to break my.
But I can't launch it.
Okay. Well, it's not going to break my heart.
Okay.
But is there any way for people to give me a thumbs up or a thumbs down on this? Like for, so all right, I got one person that says yes, they have. All right. All right, we have just a bunch of yeses. I'm getting yeses almost across the board. Hey, does anybody think no? Is there anybody who thinks no and wants to be in the hot seat? All right, I think that we're all going to generally agree that this person has most likely the cognitive ability to refuse to refuse treatment, and it is consistent with their values. So that was fun scenario 1. That was fun and easy. Let's do scenario 2. He doesn't know he's sick. Mr. Jones has no idea that he's sick. But when you tell him, hey, you have lung cancer, he goes, oh no, that's terrible. Okay. But that's okay. He's going to be cured through prayer. He is not oriented. He thinks that it's 2020. He thinks the president is Clinton. You're trying to get some orientation. He is part of a religious organization since childhood that doesn't accept medical intervention. He has a diagnosis of major neurocognitive disorder due to deficits in orientation, memory, and language. As a neuropsychologist, I am now strongly suspicious of Alzheimer's disease. Oh, hey, we have a poll. I love it. And his mood is mildly depressed, but his faith is helpful. This one, I'm curious whether we're going to get a bigger split on this. So yes or no, does Mr. Jones now have the capacity to refuse treatment? And I'm going to trust Maureen or somebody who's not me to tell me when people have voted. Or to, let's see. Oh, we've got a poll. I love it. Anybody else? All right. So, this one's tricky. Does anybody brave enough that wants to explain why they say yes or no in the chat? Because this one's pretty split, which I expected it to be. And this is actually very close to my nightmare scenario when if I'm called to do a capacity evaluation. Yeah, okay, it absolutely depends. So I'm going to want to know a whole lot more about what's going on. So, Cheryl says if he has deficits in language, can he understand the info being provided? And, the answer is probably no. So long-term memory, meaning that his memory is probably good up until, but with dementias in general, the way that it works is you still can remember things that happened a long time ago, but not right now. So your memory for what's happening now and it gets worse, it actually gets better the farther back you go. So This one is tricky. I wouldn't love it. I would say that it depends and I want more information. In a scenario like this, I'd absolutely just send to somebody else. My inclination would be, hey, it's likely that this guy would have refused treatment 5 or 10 years ago. The decision not to get treatment for lung cancer may be consistent with his values. If you really want to be messed up, I could have given you scenario 3 in which Mr. Smith wants the treatment and his son John doesn't want him to get the treatment because they've been part of this religious organization for so long. I'm not going to mess with you that way because I don't want to be put on the hot seat for that. So let's go to scenario 3. Again, he doesn't know what's going on. His history and values, so this should be actually scenario 3 if you can change it to scenario 3. If not, we'll just work with it. So his history and values, he's been treated for medical conditions his whole life, except for the last 6 months, because 6 months ago he started a new church, and this church does not let you get treated for medical conditions. And again, that diagnosis of major neurocognitive disorder, and his mood is mildly depressed, but his faith is helpful. Does he have capacity to refuse treatment? And of course, the answer is it depends. Of course, the answer is at this point, you're absolutely going to send him to somebody else to do a more thorough evaluation. But just off the top of your head, what are we thinking? Yes. Oh my gosh, Cheryl, you are absolutely right. Cheryl says I would question undue influence of the church, which is about the time that unfortunately, usually financial capacity is likely to come up in a scenario like this as well. And do we have the results of the poll? Okay, yeah, you know what you're doing. So yeah, I would say that it is more likely than not that this guy is not going to have capacity. One of the things that I'm going to be thinking about is he started this, so I'm very worried about undue influence from the church, or from whoever inspired him to join the church. Additionally, he's got major neurocognitive disorder. As somebody who's looking at dementia, it's very unlikely that if he has major neurocognitive disorder now, that that 6 months ago he was fine. So it's less likely that this is it's likely that this isn't consistent with the values that he would have had before cognitive changes. But boy, this is not something that you would just be able to make a flash decision on. You would need way more history. You wouldn't want that. You would, if he promised the church money, then this becomes a financial issue. Then we're probably even going to be looking at, what evidence do we have over the past year? This could be a forensic issue. Do we have questions about over the past year? Is there any evidence that cognitively he's been slipping to the point where he might have already lacked capacity? Very tricky to tell in retrospect. And scenario 4. Let's go back to suddenly he's with it. He knows his condition. He knows his treatments. He's been treated for medical conditions until the last 6 months when he joined the church. He has mild cognitive impairment now. Again, he's back to doing mostly okay, but he's super depressed since the death of his wife 8 months ago. He's apathetic. He's uninterested. He rarely speaks more than a yes or no. He's given you very few movements. Does he have the capacity to refuse treatment? Good luck, y'all. All right, can we get the results of that poll? And if anybody has thoughts that you want to share on the chat for this one, boy, would I love it. Okay, so overall, most people are saying yes, he has the capacity. Some people are saying no. This is maybe the trickiest of the scenarios where I would be hard pressed to say the answer, because mood can absolutely affect your ability to make decisions. I would need somebody to dive deeply into whether the person, can make an informed decision. You're probably aware of, there's been all sorts of questions There's, oh boy, Cheryl just added that, that she had a client where the girlfriend stopped all of their psych meds. Gosh, that's an awful situation. You're probably aware that, in states or countries even where assisted suicide is now is legal, that depression is a rule out, that you have to say this person cannot be severely depressed to the point that they lack capacity. Would they have made this decision under other circumstances? So there are absolutely things that could affect yes or no. Maybe a person says, hey, look, I've lived a good life and I'm uninterested in really going through some hard treatments without my wife. And that person may have capacity. On the other hand, maybe we can't get two words out of this guy. Like maybe he can't actually, understand the ramifications of decisions. Maybe if he were using psychological medications, maybe then he would want treatment. So this one is awfully tricky. We're not going to be able to get a yes or no. This is absolutely going to the situation, his context is going to matter a whole lot. So we're getting a lot of really helpful thoughts in the chat about things who can help with some of these. Certainly, the specifics of the disease or the treatment or the quality of life would impact a person's decision. There are a lot of reasons why a person may not want to be medically treated. So we want to know, do they understand the ramifications? This is going to go back to their ability to make an informed decision. And are they making a decision that is consistent with their known values? So these are all, this is a made-up scenario to help you try to get a sense of what factors could impact a person's ability to make an informed decision or not. So there was a question about, do I recommend a capacity assessment by a neuropsychologist on complex cases? I do. There may be some, there are other places that you can reach out. The benefit of a neuropsychologist is that a neurologist might see somebody for 15 minutes or a half hour or an hour. And I work with somebody usually for, 3 or 4 hours. And I'm not using screeners. And my evaluation can really, those patterns that I'm looking at can get a really good sense of, hey, if somebody has a problem with their cognitive functioning, does this look more like a dementia? Is this the pattern that I see when somebody's too depressed to think well? Or is it the pattern that I see from, or is this actually kind of normal aging? Does this look like it's normal for them? So thank you everybody for coming through this. I'd love to answer any questions, or if anybody has any more thoughts about some of the kind of tricky issues that can come up with questions of capacity. Do feel free, by the way, to reach out to me if you have any questions. That's my website and my email address. I also included on this those resources that I mentioned before, the Older Adult Nest Egg, which is going to be good for financial capacity questions, and the APA guide for diminished capacity if you're trying to get kind of a screener. So a little bit more information for that. So thanks again. Anybody, any questions, any thoughts?
A lot of thank yous on the chat, Dr. Werschbach. Thank you.